what I wanted to cover today was this general topic of meaningful use in analytics, and talk generally about meaningful use, and sort of give a sense of how far do we think that that's going to take us toward what we think is the holy grail of analytics, right? And when we talk about just generally, and even for those who aren't in healthcare, talk about electronic health records, health information exchange, all of this, there's that big data concept, right? And in the last couple of weeks, I'm amazed at how much big data is popping up more and more, as sort of this term of jargon, this buzzword, and sweeping across kind of every industry. And the hope and expectation is that big data is going to get created by all of the infrastructure that's being laid now, and by the meaningful use incentives that are out there in the economy. Well, I don't want to completely disabuse you of that notion, but I would say, just to get to the punchline here, and then we'll walk through it, is that meaningful use lays a very, very thin foundation for the accomplishment of the kind of analytics that all of us would hope we'd be able to get from this stuff. And it's going to take a lot more beyond meaningful use to be able to use that foundation to get us to the level of analytics that we need to just be able to measure and improve care in some fundamental ways, let alone the more advanced things that you just heard from the gentleman from IBM. So the problem that I'm more focused on is not about the great analytics that a Watson or any other analytic engine could produce. It's about how do you get the data there in the first place. Watson's great, but I would just submit that in healthcare right now, Watson would be analyzing nothing. For most of the data enterprises that we have, and certainly if you try to bring together most of that information, the data is just not there. And then when it's there, it's full of more holes than actual sort of filler. And the problem with that, then, when you apply any analytics engine, is that the variation you're going to get is more about the unreliability of the data itself. And the mismatches in the data and the definitions of the data than it is about this analytic tool versus that analytic tool versus that analytic tool. So let me just jump in, and as I said, I'm happy to stop along the way and answer questions, or really turn this into a discussion if that's appropriate. So who are we? Who am I? The Mass Health Collaborative is a nonprofit organization. We were founded in 2004 with significant backing from the Massachusetts Medical Society and the American College of Physicians on the physician side, and Blue Cross Blue Shield of Massachusetts, who provided us with initial funding of $50 million to run a community-wide or statewide experiment in health information technology. What we did is we selected 3 communities in Massachusetts. We outfitted them with electronic health records. All the clinicians in those communities, so it was about 600 clinicians across 3 communities. We outfitted them with electronic health records that we paid for with the Blue Cross funding. We created standalone health information exchanges in each of those 3 communities so that the physicians in the hospital could communicate with each other in real time. And we created a quality data warehouse on top of all of that. So this is the general architecture that we created. And I'm not going to belabor the point, but I just wanted to give you a sense of where we're coming from and where I'm coming from as I speak to this. And I'll give you some very specific examples of what we're doing now, because they're emblematic, I think, of the state of the industry, and can give a lot of lessons learned about what we can accomplish with what we have today, and what we really can't accomplish, and what we're going to have to sort of wait and see how the market unfolds over the next few years to be able to see what direction that takes. But what we did is we implemented electronic health records, as I suggested down on the bottom. 4 different EHR systems is what we did. Remember, this is 2004, 2005, so it was well before any certification programs or anything like that. Then we created 3 standalone health information exchanges, all with different degrees of success in terms of the business sustainability. Quality data warehouse on top of that extracted in real time patient-identified information into that warehouse. And then that was originally conceived to be for research purposes. It's now a commercial data warehouse that we offer as a commercial service to clinicians and to hospitals for data reporting, data analytics, what have you. And that's what I'll describe in greater detail. So let's just step back for a second and think about this question of analytics and the question of how far is meaningful use going to get us. So one question, again, I think that we might ask ourselves, and I certainly ask myself because I'm relatively new to healthcare. I began my career actually working in the Pentagon for 7 years, then went into academia, and then worked for the Boston Consulting Group as a strategy consultant for 6 years, and then finally sort of ended up in healthcare and health IT. So in looking at this, I sort of always am wondering, well, why isn't this just happening? And we don't have to go through these, huge programs and this incredible effort and this incredible lift to create the kind of analytics functions that we're hoping for here in banking or in any other sector that you can think of. Well, you kind of think about all of the sort of the foundational pillars of how we think about the rest of the economy, right? Going back to Schumpeter and creative destruction and Albert Handler and scale and scope and all the great benefits that you get as industries start to grow, crossing the chasm, the innovator's dilemma, and since I worked at BCG, I have to talk about blown to bits. But all of those were about the way technology is used in the business setting to create efficiency. Right? And almost all of those are stories about technology in some different way, shape, or form starts to sweep across an industry and fundamentally change the complexion of that industry. I would submit to you that none of those things really fully applies in healthcare, and that's been a part of the issue. Not because healthcare is, not because of evil people, but because of the structure of the healthcare system. There's a lot of perverse incentives with respect to the economics, but there's also some structural differences in the healthcare industry that are very different than other parts of it, and that's what makes the meaningful use part of this very, very hard. So what are some of those structural elements? First off, our healthcare system isn't really a healthcare system. It's not a system. It's a very, very, very scattered group of individual provider organizations and individual purchasing organizations who somehow interact with each other in a very localized way. So if you look at if you look at the 670,000, almost 700,000 column practicing physicians in the US, about 150,000 of them practice in hospitals. And about 2/3 of them are in community hospitals. So they're not in Partners Healthcare, they're not in the Beth Israel system, they're not in sort of Geisinger. They're in the community hospitals, right? Which is itself a very fragmented part of the sector. If you look at the other 520,000 ambulatory physicians who are in the ambulatory side, about 70 to 80% of them are in small practices, either solo practitioners or 2 physician practices, right? So again, to the extent that we think about Geisinger, Kaiser Permanente, Mayo, Mass General, Beth Israel, Atrius, where I get my care, Harvard Vanguard, what I like to say is, though, you should just blot those out of your mind. Those are perversities in the market. They are absolute perversities in the market. We in the Boston area happen to have, fortunately, we have an oversupply of those in some ways. So from a care perspective and from a quality perspective, not from a cost perspective, that's a very good thing. But for the rest of the country and for most of the country, it's not like that at all. It is a very, very fragmented system. Just to give you a more illustrative sense of that, I looked at the Department of Commerce publishes what they call Herfindahl indices, which are concentration, measures of concentration in industry. And what they do is they say, well, what % of the employees in a particular segment are in the top 50 organizations or companies? And then they sort of rank those. And as you can see, physician offices is all the way down at the bottom, ahead of florists. So only florists are less centralized than physician offices. And one of the things I like to point out is, even so, I could, on my Android device right now, order flowers in San Francisco and have them delivered today. And I couldn't do anything, literally anything, as a patient with this Android device that's really meaningful from my perspective as a patient, even though Mass General and Brigham and all of those are right down the street here. Right? So it's a fundamental difference. That fragmentation is on the demand side too. So what I've shown you is the supply side, right, which is the provider organizations. The demand side is the same. When you think about, there's something like 1,000 health insurance companies in the country today. All of them are very local. We think about the Aetnas and the WellPoints. All of them are nationally big, but they're small locally, right? In almost any market, they're small. You look at Massachusetts, the commercial health insurance market is dominated by local players who are nonprofits. The Aetnas, the Cignas, all of that are very, very small pieces of the market. So in every market, they're very small and it's very fragmented. So when you have a situation where you've got fragmentation on the supply side and fragmentation on the demand side, you don't have the opportunity for a Walmart, let's say, or a Sabre to come in and say, we're going to sweep through this industry, do a ton of consolidation, and invest to scale in technology and fundamentally change this whole thing. And we're going to use analytics to really drive the industry and drive greater value in the industry. Now, we can all argue about whether Walmart delivers value or doesn't deliver value, whatever it is, but arguably what they have done is they have consolidated a whole bunch of stuff. They've leveraged technology to drive prices down in very, very, very efficient and effective ways, right? And again, not suggesting that we want that necessarily in healthcare, but in healthcare it would be very hard for that to even happen. I mean, we have the Kaisers and the Mayos, but you look at how they do it, right? They just do it very selectively, but they're not going to sweep across. They're not able to get that kind of scale to sweep across. So it's not only about technology, though, it's about clinical practice. Every one of those places practices differently. Right? So what Walmart does is not only about technology, or Bank of America, another great example, but they have ubiquity of process. Right? And they basically say, these are the processes that you're going to use in the Bank of America branch in Boston, and in Topeka, Kansas, and in San Francisco, and in Ingleside, Texas. And anyone who doesn't like that, well, you can go work at another bank. Right? We don't have that in healthcare. We don't have that in healthcare. So, so those are some of the challenges about how, it's very hard to sort of think about commonality of form, commonality of process, and commonality of infrastructure that are all sort of the key components of driving an analytics solution that actually gets you to a place where you can actually compare meaningfully all of the things that are going on in the market. Doesn't mean it's an impossible task. And of course, one of the biggest challenges is that every one of those small practices looks something like this. And this is not to make fun of them. This is an actual practice who we work with, and I'd never make fun of them, but it's a challenging environment. And for any of you who go to small primary care practices, you know it's a very challenging environment. And in many ways, it's a miracle and a testament to the high quality of the individuals involved and the mission orientation that they have, that in that kind of mess that is not their fault, they deliver high quality, safe care every single day. So let's talk about meaningful use. What does meaningful use do? And then we'll get to, what doesn't it do? Well, the first thing to recognize about meaningful use, and it's sort of depicted there on the right, meaningful use is a program that was created by ARA. Right? It's from the economic stimulus. I think all of you are hopefully familiar with that. Importantly, especially this week, it is not a part of the of health reform, or Obamacare, as some people like to call it. Right? Completely separate thing. That's not what they're debating up in the Supreme Court. On the left-hand side, though, I do like to point out, because this is true in every state, there are state peculiarities that impose on this question of meaningful use as well. And in the case of Massachusetts, we have Chapter 305, which presents and poses its own set of requirements that are above and beyond what meaningful use might require. And in our federalist system, every state has some of these unique kind of aspects to it that one has to take into account. So here's another example of the ways in which you might think even the federal government could come through and say, we're going to sweep across and have meaningful use be this sweeping kind of thing that can raise everyone, but oh, wait a minute, I got 56 states and territories, and each of them has the ability to tweak this in some way, shape, or form. And every vendor and every provider needs to think about those things. So I'm not going to dive down into the Massachusetts. Okay, so here's one picture of meaningful use. I got this from ONC. I didn't find that particularly illustrative, and one of the things that I try to do in such settings like this is try to clarify things rather than confuse things. So I went over to CMS and I got a different picture, and this is what they gave me. And again, not to make fun of anyone, because this stuff is really complicated. But I go back to, this is my own picture of meaningful use and what it is. And again, as we start to think about how this will drive analytics, in what parts of analytics it'll drive, one of the things I like to point out is just follow the money. At the end of the day, let's not worry about which assistant secretary reports to which assistant secretary. Let's just think about the overall dollars. Roughly $30 billion in the HITECH program. 28 out of the $30 billion is in individual payments to individual providers and provider organizations. So to ambulatory physicians and to hospitals. Individual payments according to their individual ability to meet a set of requirements. And then $2 billion on top of that is for infrastructure of various ways, shapes, and forms. Of the $2 billion, $600 million is for health information exchange. So if we just stop for a second and think about the needs of analytics and what are the needs of analytics, I think we would all probably agree that in a part of the economy that's as fragmented as I described, that you can't possibly have meaningful analytics without having meaningful health information exchange, right? If all those little tiny islands, they're not even islands, they're little seeds, if all of them can't in some way meaningfully exchange information, and we can't meaningfully and efficiently aggregate that data, then we're not going to be able to accomplish anything with respect to larger scale analytics. Sure, every one of those individual places might be able to do their own analytics, but that just serves their own individual needs, right? So in a way, it depends on what question you're trying to answer. So health information exchange is a fundamental part of that. So for those of you who are hoping that HITECH was going to solve the health information exchange problem, let me completely disabuse you of that notion. It's $600 million out of the $30 billion. $600 million out of the $30 billion is being applied to health information exchange. And it was divided among 56 states and territories, as described there. The biggest award went to California, which got about $40 million, and then the smallest went to very small states like Wyoming, New Hampshire, who got something like $5 to $6 million. If you think about Massachusetts, Massachusetts got about $12 million. $12 million, well, it might sound like a lot. $12 million over 3 years, a state the size of Massachusetts. I mean, that's the IT budget of a medium-sized hospital in this area. That's not even, that's not even close to being what you would need to create anything meaningful on a statewide level. So, and again, that's not a fault of those designing the program. That's just the money that was made available. So, but one important point for us to realize here, and it's true with electronic health records as well, and I also especially like to point it out to employers and commercial health plans, who I think are, some of whom are standing on the sidelines and hoping that this foundation has been laid, or these crops have been planted by the federal government, and now we just sit back and wait for them to rise, and then we come and we yield them. And it'll be bountiful and plentiful for all, and that's just not going to happen that way. It's not going to happen that way, in part because they're only going to grow, it's only going to grow this much, and it's going to be not evenly distributed. As William Gibson liked to point out, the future is here, but it's very unevenly distributed. So some places like Mayo are going to go, and some places, most places, are going to be way down here with very, very little capability. So how do we think about that challenge and meet that challenge? So meaningful use is the other angle on this, right? Because there was a supply side that created the health information exchange, but a fundamental driver of it, and I think that this was very well intentioned and actually very thoughtful in some ways if you think about it. The $28 billion put money into the hands of the clinicians, and in part said, this is a problem of demand. This is a problem of consumers, meaning physicians and hospitals, not being demanding enough about the products that they wanted. Leaving aside, sort of the Steve Jobs perspective about consumers, the last people to know what they want. But let's just assume that consumers have some idea of what they want. And the problem of health and IT, in some ways, the idea is that they don't demand enough. And that if we just give them purchasing power, their purchasing power will create better products, and if we incent them also to want to do certain things, like health information exchange, like structured data in their electronic health records, that'll generate demand and the technology will come to meet that demand, right? That's kind of the idea. So, so meaningful use says you should use EHR technology in a meaningful manner. You should do certain types of electronic exchange, of health information exchange, and you should submit clinical quality measures. That sounds like analytics, right? Clinical quality measures, and offer those measures, to CMS. So all of that is underway, and the idea isn't to suggest that it's not all underway, and also not to suggest that progress isn't being made, because progress is being made, I think. The challenges are that it's very, very narrow, specific progress in a very, very complex area. So one of the things that I like to think about, again, stepping back for a second and saying, well, how far is meaningful use going to get us? Well, let's not think about, let's think about the business of this. So, at some point, all of these meaningful use dollars are going to flush their way through the system and have accomplished a whole bunch of good stuff, that can be a separate conversation if anyone wants to discuss that. I think, from an economic stimulus perspective and from a laying down the foundation perspective and from a public goods perspective and from an investing in the supply chain perspective, just like Walmart and Toyota do every single day. There was many, many, many good arguments for having Medicare and Medicaid make the kind of investments that they have. But if we think about the world of healthcare organizations depicted there on the bottom, you have sort of all the way on the left-hand side independent actors. Those are the onesie-twosie physicians. North Adams, Massachusetts, great example. There's no contracting network out there. You have solo practitioners, specialists, primary care, all of them affiliated with the hospital, but there's no IPA, there's no PHO. Each of them is basically on their own fee-for-service contract, just like their fathers and mothers were 40 years ago, and their grandparents were before that. Except I guess before that there was a lot more cash payment. And then you start to move your way up to levels of concentration. You say, well, Now there's more organization. There's IPAs and PHOs who are bringing together these contracting networks. And those are plentiful on the market right now, as we know. And then we start moving right to accountable care. I always like to take off the O from accountable care because we don't really know what accountable care organizations are. I think we know what accountable care generally is. It's directional. It says it's this way and not that way. But we still don't know what the O is. And the O is defined by many different people. If you're Blue Cross, you define it a certain way. If you're CMS, you define it another way. If you're CMS bundle payment, you're one way. If you're ACL Pioneer, you're another way. So each of those endpoints is a little bit different. But again, we know directionally what it means. And then finally, you're an IDN. You're a Mayo, you're a Partners, you're a Beth Israel, who has a whole bunch of organizations that you sort of gobble up and say, I'm going to draw a circle around you and call you my company, and I'm going to treat you like one company. I'm going to start, implementing infrastructure and processes and administrative processes and business processes to make you all work together. Well, what are the technical and health information exchange and analytical kinds of functions that you need in each of those categories? Well, if you look all the way on the left, the independent actors, for meaningful use, and I would argue that's really as far as meaningful use goes for the most part. It's basically saying you need electronic health record, and you need to be using it, and then you need to be doing what I would call clinical messaging, which is for those of you who are in the inside baseball of this, direct with a capital D. So, which is basically it is just secure email. It's really nothing more than that. It's just secure email. It allows you, and not that it's not valuable, but that's it. It allows you to push stuff back and forth. It is certainly not the vision that people have of data being cleansed, aggregated, normalized, and available for analytics. Or the physician dream of, I just want to be able to query the system and say, are there any records on this patient who just showed up in my office? Right? It's not going to accomplish any of those things. But that's really as far as meaningful use gets us. But then you start to think about, well, as you start to move to the IPA world, you start to really need measurement and reporting and registries and repositories, right? You really need to be able to start doing that. And as you start, and again, these aren't fine lines. There's obviously a very blurry, sort of distinction here. But as you move toward accountable care, you're now talking about managing risk in a real fundamental way, meaning that you lose money if you are on the wrong end of that, of that calculation. So you need to start having more elaborate case management and patient access, case management, longitudinal records, and patient access, as well as population risk and financial management. You need to have those capabilities. So bringing together the clinical information with the claims, with the financial information, to be able to start to look at that in a way that can help you manage risk. You need to be able to measure risk first, and then be able to figure out what are the processes to manage it and mitigate it in ways that make sense. And then finally, once you get to the IDN, you just have that enterprise overlay that says I'm the partner stamp. That's what I put on, on all of this. All of you bill in the same way, et cetera, et cetera. So again, the thing I like to point out here is that meaningful use is only going to get us a certain way of the way there. And certainly maybe some organizations, like the Mayos of the world, the Geisingers, the partners will grab it and they'll bolster up their foundation, but they were already moving right, far to the right anyway. So it enables them to bolster their foundation and really, then use those resources to sharpen the capabilities they have on the right. But for the most part, we're going to be relying on the market and accountable care and whatever's going to happen after meaningful use to really get us to these kinds of capabilities that need to be focused on value and what the market is valuing as opposed to what meaningful use is trying to push people toward. So I think that's really one of the fundamental challenges that we're going to have, and why I'm very very sort of praising of what meaningful use is going to accomplish, because without those EHRs and without at least that initial sense and that sense of inevitability among the individual physicians that, I have to get an electronic health record. And it's very seldom that I meet a physician who doesn't have an electronic health record somewhere on their roadmap if they don't already have one. So that's a very, very good thing. I mean, you can't do any of this stuff without it. But the point is, it's just the meaningful use itself is not going to get us that far beyond that. So what are some real life examples of some of the issues? And someone is going to have to give me a sense of when I have 5 minutes left. I'm going to keep talking until someone waves their hand and says, you got 5 minutes left. Sorry? 5 minutes, all right, now I was afraid that was going to happen whenever you ask the question. So this is, we have a quality data warehouse, as I said, and this is not to advertise our quality data warehouse. I just want to talk to you about some of the very specific lessons that we've had from the bleeding edge. So, we just have, it's a web-based solution, we aggregate data. Oops. So one of the things that we do is, starting all the way on the left, which is those Massey Health Collaborative pilot projects that I talked about, we started aggregating data through those systems, and we were using whatever standardization was available at the time. The continuity of care record, which was created in part by the Massachusetts Medical Society here in Massachusetts, HL7 messaging, what have you, in a way to extract that information. And then we did a project with the Mass Medical Society, learned a whole bunch more about the, sort of the wide variety of standards out there, and the great thing about standards is there's so many of them. And now we have production systems with the Adirondacks Health Institute up in the Adirondacks region where we get real-time clinical data from about 200 providers who are using 7 different electronic health record vendors. And that's a production system now, and we get continuity of care documents and structured data every single day, process that, provide quality measures back to the health plans who are supporting the patient-centered medical home project up there. And then finally, Beth Israel Deaconess Physician Organization here in Massachusetts, we are the quality data solution for them. So we get all of their data from the ambulatory side, we process it, we do their reporting to Blue Cross, to CMS, what have you. So anyway, again, that's not to advertise, just to give you a sense of what's the scope of our activities and what are some of the areas that we might have learned some lessons. So the quality data warehouse, one of the issues that's, that as we think about, well, how would we scale this kind of thing? And if you think about this as being one example of a place that's trying to do something with a leading provider organization, and Dr. John Halamka is the CIO, one of the leading figures in this area. They have about 2,500 users on WebOMR, which is their homegrown EMR. They have about 300 users on eClinicalWorks, which is the ambulatory affiliated physicians. And one of the problems they had as a network was they have disparate systems. So how are you going to do analytics when you have disparate systems, right? So that was their first problem. If they were all on WebOMR, they could have developed something internally. If they were all on ECW, they arguably could have developed something internally. If they're all on Epic, well, let's not talk about Epic. But if they're all on one of those, arguably they could have done that, but they're not, right? And that's the reality for many, many, many organizations, if not most, is that you have disparate systems, and now as we think about accountable care, that problem is getting more complex because accountable care draws those lines in very funny ways and starts to bring in a whole set of provider organizations. So the value of the warehouse is saying, all right, we can take disparate data from different EHRs and start to do the analytics on it. But it does raise the question of, is every organization now going to have to do that? Are they going to have to think about some now separate system to do these kind of analytics? And that's yet another layer of complexity, yet another sort of solution they have to go out and find. And then we present it back to them in a variety of ways, right? And that's all depicted there on the right-hand side. But what has struck us as we thought about this, and I'll just talk about this for a second, is is that we had to spend a lot of time, year and a half, on first working on the left-hand side to get the documentation right. So first off saying, what is it you want to accomplish at the end of the day as an organization? What does that mean for what you need to document in the electronic health record system? Because remember, clinical documentation is different than documentation for analytical purposes. Just because, and the people who are documenting need to know what it is you're trying to accomplish at the end of the day, and importantly, need to care about your need as opposed to their need, right? Clinicians are focused on practicing medicine and practicing good medicine. They're not focused on, oh, I need to enter it this way so that those people can measure me, right? That's not, the first and foremost thing on a clinician's mind. It doesn't mean they can't be brought around to that, but if they're not aware of it at all, the chances of it really happening systematically are exactly zero. So we spent a lot of time doing that, and then had vexing problems with the connectivity. I mean, unbelievable problems with getting the documentation according to a set of standards out of each of those EHRs, transported over NIHIN, which is a health information exchange here in Massachusetts and a very highly regarded one. And all sorts of issues. I'm happy to talk about some of those details with, always having to compromise with every point on the system to say, well, there's a national standard called this. NIST, the National Institute of Standards and Technology, puts out a validator that you are supposed to be able to take a standards-based document, run it against the validator, and it's a pass or fail. And if it fails, you're supposed to be able to go back to the vendor and say, it failed, fix it. Well, what do you do when the vendor says, I don't care about that? Who cares about it more? Well, it turns out we do. We care, Beth Israel and we as their agent care about it a lot more than the vendor cares about it. So that's when we start making compromises. And we start saying, okay, well, let's figure out why you failed the validator. And okay, well, let's figure out how we spoof the validator. Let's figure out how we do an end run around the validator. Do we even need the validator? Well, who cares about the validator, right? And you start going through all of those things. And again, if you start thinking about, well, geez, if this is one provider organization having to do this with every single one of their vendors and having to have a different approach to each of their vendors, I'm not saying I'm not saying it's impossible. It's not. I wouldn't be in this business if I thought it was impossible. But it's just more more challenging, I think, than many of us really appreciate. And needs to be driven more by business dynamics than just saying, here's a set of standards, here's technology, go and use it, and great stuff will happen, right? That hasn't been true in any part of the economy, where you hand people technology and they do great things. It's more about saying, what are the purposes we want to accomplish, and how do we deploy technology in a way that will allow people to accomplish those things that we all have in common. So just to give you another example of some of these challenges, we did a pilot project. I'm going to end in 1 minute. We did a pilot project with Pop Health. So for those of you who don't know Pop Health is an open source tool that is now being promoted by the federal government. It was created originally in New York City as a part of the Primary Care Information Project that Dr. Farzad Mostashari led in New York City. He's now the National Coordinator for Health IT. So he developed that. They developed that originally in New York City, and now it's being made available at the federal level as an open source data warehouse tool. So literally anyone can take it, start to try to populate it. So one of the things that the National Coordinator's Office asked us if we'd be willing to do is just do a side-by-side comparison. So they wanted to say, let's take a real commercial data warehouse that has some real data and has been really doing this, and then compare it with this open source tool and see what we get. Both of our systems are certified. Right? So we've been certified for meaningful use, ONC, pass with flying colors, so there's not an issue of one being certified and one not. We're both certified for PQRS as well, right? So we're both certified. Well, and so what we did is we took 1.9 million records from Beth Israel Deaconess, ran them side by side, processed them side by side through the eHealth Collaborative Quality Data Center and Pop Health, and then we looked at the results. And I know all of you were thinking, wow, and it came out exactly the same, and it was perfect, and we can all, now do our big analytics. And of course, that answer would be wrong. What we found was incredible diversity. And some of it, a lot of lessons learned. But we didn't have, of the 44 meaningful use stage 1 measures, which are the required measures, the set of required measures for stage 1, we didn't agree on a single measure. Not in a single measure. And the 3 basic reasons were, 1, we had differing definitions of what the basic document was, the continuity of care document. We had fundamentally different definitions of what that was, not according to standards, but according to what it should contain generally. We define it as something that is an episode-specific document. So at the end of every encounter, a clinician locks his or her notes, it generates an episode-specific CCD and sends it to us. We get 40 to 50,000 of these a week from Beth Israel. The Pop Health assume that you get a CCD and it's the history of Mickey Tripathi back to his birth, if that data is available in the electronic health record. It's a very different conception. It seems like a trivial difference. It turns out to be a real big difference if you're starting to try to interpret, well, what data am I getting here? And what am I not getting? And how do I sort of make sense of all of this? So you think that was a little bit scary to realize, wow, we don't even agree on that. The second area that led to a lot of these discrepancies was varying code sets. Right? And even in a place like Beth Israel Deaconess, where you have Dr. Halamka, who is the chair of the standards committee, we still have varying code sets from what meaningful use says you should use and what is operationally used in the organization. So meaningful use says you should use RX norm. Beth Israel Deaconess uses NDC. Meaningful use says you should use SNOMED for procedures. Well, Beth Israel uses CPT, like everyone else in the world does. On and on and on and on. So we did all the mapping for that, but of course then Pop Health tried to do that mapping, and it's a many-to-many mapping, so there's a lot of ambiguity in that mapping, so it led to wide discrepancies in that. The third difference was that the definitions of the measures leave themselves open to wide interpretation. They're basically PDF documents. And every organization, every vendor, whoever it is who's creating this, is supposed to take these PDF documents and basically program it themselves. Rather than saying, I'm going to give you a set of algorithms that you can consume electronically and that your system will automatically then take those as commands and interpret and run those, right? Which would be the way that you would get uniform definitions. But one of the, and I'll stop right after this, one of the differences that led to actually wide variation in some of the measures was, what does it mean to be 64 years old? So our definition of 64 years old was, if someone was born yesterday, if someone turned 64 yesterday, they're 64 today, and they're 64 tomorrow, and they're 64 until they turn 65. The Pop Health definition was, no, you were 64 on one day. You're 64 and 1/365th today. And tomorrow, you're 64 and 2/365ths. and so on and so on and so on. So not surprisingly, they had very few people who were exactly 64 at the point in time. So again, you would think these are kind of trivial things, but then you start to add up, wow, every one of those measures has that kind of issue and that kind of discrepancy. And if every electronic health record is supposed to be doing that, we need a lot more in the way of standardization in the way these systems are going to consume them, and more importantly, in the way people think about their own processes and the continual vetting of these to really make this work in a more scalable way. So I know I'm over my time. Thank you very much.